Thank you very much, guys, for being a part of this, another session. First of all, I like to thanks everyone for being a part of National Overseas Doctors Family UK teaching group, which I'm really grateful to. Just to give you a brief review that we are doing this teaching sessions for quite some time. And now there is so much good and positive response that we are giving regarding our teaching sessions that it has created a vibe of understanding, a vibe of progress, and a vibe of teaching for the other people also to join us. So now what we are getting is that instead of just confined to the United Kingdom, we are getting the speakers from all over the world to come and speak on our platform. I'm also thankful to the federal government for Yare Watan program for being a part of their teaching program. And I'm also thankful to all the audience, especially the teaching team and the consultants of National Overseas Doctors Family UK, which is NODFA. So before I start this session, in our last session, we have got some problems. That's why this session, we have restricted the people to join the Zoom link. We only allow those people to join the Zoom link who are properly registered with us. So to stop any kind of hacking or any kind of foul language or bad wording to be used in this very important teaching session, because you can well imagine that the consultants who come on these teaching sessions, they are very, very busy, especially during the COVID-19 period. And they take their time out to teach you guys. So we just want to make sure that they are safe. Their identity is safe. Their account is safe. So that's why this session, we have restricted it a bit. So before going into further details, the topic which we are going to discuss is a very, very relevant topic. And I think so it is one of the most important topic that NODFA has done the teaching and the educational session on it. The topic is the current lung cancer treatment landscape and impact of COVID-19 vaccine. I've got two very high class, I must say, very renowned, speakers with me. And their work in their field is appreciated and regarded worldwide. And I am really grateful to them that they have taken out their time, especially over the Saturday, to do and teaching with us. The first one is Dr. Vijay Prasad. He's currently a clinical director at Roche and Genetic UK. He's one of the topmost person who's doing all the research element. Previously, he was the director in global oncology R&D at New Jersey, USA. So Dr. Vijay Prasad, thank you very much on my behalf, on NODFA behalf, that you have taken your time and come for the teaching. The next one, I know this person since he was a very junior doctor, and the way he has progressed in his career is just amazing. And I am very proudly to tell about him that I know him for more than 20 years now. And he started as a very junior doctor as an F1, and nowadays is one of the most renowned, popular, educated, and well-respected surgeon in UK. His name is Dr. Asif Shah, who is a consultant cardiothoracic, heart and lung transplant surgeon in UK. So Dr. Asif, thank you very much for joining us. That's really appreciated. So without wasting any time, I will give the mic to Dr. Vijay Prasad to please start his presentation and teaching session.
Thank you, Dr. Kasif. Thank you for inviting me again to come to NODFA and talk about uh, the current treatment landscape of lung cancer and the impact of COVID-19 vaccine. I think some of the members who are attending again would be familiar with my previous topic. If they are not, then it was very much when it was pre-vaccine times, and it was a literature review on what are the current vaccines in development, and where we are with the vaccines. And it was basically an introduction to vaccine strategies, types. But times have changed, and times have changed quite rapidly. And we are in the post-vaccine world. And in the clinical trials that I am running or helping out in running as the medical monitor and study director, there are new challenges that we are facing. And today I thought maybe I will introduce the audience to what's going on with lung cancer therapies. Where were we, and where are we now, and which way are we heading? So I'll try to share my screen. I hope the technology helps and doesn't give up. So that's the screen to share. Perfect. And are you able to see my screen?
Yes, we are able to see. If you make it a big, then it's a yeah.
Yeah, perfect. Lovely. So here's the topic, but let me jump right into the content. So Dr. Kasif advised me that let's keep it a more high level, so we have some time to discuss as well. So when I was a medical student back in 1996, when I started medicine, I think a couple of years down the line, we were introduced to pathology, and we went to the pathology labs and we saw lung cancer slides, and we learned that lung cancer is broadly divided into, histology-wise, broadly divided into small cell lung cancer, which forms about 15%. I'll try to use the laser. That's the laser pointer. Perfect. So SCLC, or small cell lung cancer, and the rest of it is NSCLC, or non-small cell lung cancer. So this is the histological classification. And the reason for this division is to help with treatment, to administer treatment. There are further subdivisions with the NSCLC, the non-small cell lung cancer, into adenocarcinoma, squamous cell cancer, the large cell, and the other. So this was then. So today I'm going to kind of narrow down on the adenocarcinoma, the NSCLC, non-squamous, non-small cell lung cancer. So what was the situation like? So in the year 2000, when I passed my final year in medicine, the 1 year survival of a lung cancer patient, median survival was 7.9 months. I'm pretty sure all of everyone in the audience appreciate this is very short. So from the diagnosis of cancer, lung cancer, advanced malignancy, which is stage 4, the median survival was merely 7.9%. And here is the Kaplan-Meier curve, which pretty much showed that all the chemotherapy approaches that were being tried, there was no particular difference. As you can see, all of these lines are intertwined, and at around 30 months, nearly all patients are dead. So this was then. Clearly, the paradigm needed to be shifted. And this was around when I decided to devote my career to oncology. I think it was 2001. I don't want to go into that, but that was the start of the journey where I pretty much picked up the fight with cancer. So this is where we are now. This is a slide from 2019 Nature Reviews Cancer to show what's going on with the subdivision of the non-squamous, non-small cell adenocarcinoma of the lung. I just want to go back to this simple slide of, hey, histology. We are looking at it under the microscope, and this is how the subdivisions are. Fast forward as small as 19 years. Sorry. Okay, I'll continue. So fast forward 19 years, and you have the cancer being subdivided into multiple categories, which is sorry, I'm hearing some sounds. You're on mute, Dr. Kasif.
Okay, now unmute. If I request everybody just to stay quiet, and the things which I have pre-warned you, just keep it in mind, please.
Sure. Okay, so let me go into this genomic classification of non-squamous non-small cell lung cancer. So the subdivision of these cancers are into KRAS. 29.9% cancers are KRAS mutant positive. Around 30% of cancers are EGFR positive. And as you can see, there are so many other mutations that have been identified, and we have targeted therapy for some of these mutations. So rather than giving a blanket chemotherapy approach, we are now able to identify individual mutations and drug those mutations. So some of the key mutations are KRAS, EGFR, BRAF, HER2, MET, ALK, ROS, RET, MET, HER2, MAP kinase 2, NRAS, HRAS, and fibroblast growth factor receptor 1, 2, and RIT, and other genes. So, I'm not kind of, spelling it all out. These are well identified driver mutations, and there are drugs that can be offered to these patients targeting these mutations specifically. Right. So I'm going to talk a little bit more on just this mutation subtype, which is the EGFR mutation. So to give you a bit of a background, this mutation was identified, EGFR, epidermal growth factor receptor mutation was identified in lung cancer only back in 2004. I was in Sheffield doing PhD at that time in cancer immunotherapy. And this was when there was a couple of drugs in development, not specifically for EGFR mutation, but for lung cancer in general. And these, what it turns out to be, our first generation tyrosine kinase inhibitors. My previous boss at my previous work was involved in this development a little bit later on. But he described to me how they stumbled on identifying patients who were specifically benefiting from these drugs. So these were meant for all NSCLC to start off with. But then Providence has it, serendipity has it, keen drug development with a evidence-based approach has it. The way the whole story unfolded, I felt, a book needs to be written on how it was identified that a subgroup of patients with EGFR mutations, the story of the pie chart was still being written. Before that time, it was just histological classification. And when they saw that patients who did not smoke, women, and patients of East Asian origin were specifically benefiting from these therapy in subgroup analysis. And when they deep dived a little bit further into their genome, they identified that patients with EGFR mutations were indeed benefiting. And around 2009, 2010 was when the first line gefitinib, erlotinib was approved for EGFR mutation positive patients. And I was a registrar in medical oncology back in York around 2016 when I performed a 5-year audit of all the patients on EGFR tyrosine kinase inhibitors at our hospital at York and at Harrogate. And it was very interesting to see that the patients in real world evidence were also benefiting similarly as patients were benefiting in these pivotal studies that demonstrated and got the approval. And fast forward to now or last year, we have multiple generations of EGFR tyrosine kinase inhibitors approved. First generation, second generation, third generation TKI. Osimertinib is one of the currently widely used third generation EGFR TKI, tyrosine kinase inhibitor. So I think I'll come back to this slide in a bit. I think the timeline of development is very interesting that, you know, a mutation that was first identified in 2004 had a drug in 2010, and fast forward, 10 years, you have 3 generations of tyrosine kinase inhibitors. That's the pace with which the drug development is currently ongoing. Please, do you recall what was the overall survival, median overall survival for lung cancer patients? Nearly 7 months, 7 to 8 months back in 2000. Contrast this to overall survival updated data from the osimertinib study. I think it was published last year, 2020. And you have an updated overall survival of 38.6 months. That's little more than 3 years. So in the last 20 years, this subgroup of patients who were at increased risk of death from driver mutation, who had about 7 to 8 months to live, a median survival was nearly just over 3 years. I think the Kaplan-Meier curve pretty much shows that when compared to second generation and first generation tyrosine kinase inhibitors, osimertinib, which was third generation tyrosine kinase inhibitor, provides a superior benefit. So this is EGFR. I think in the previous pie chart, you were able to appreciate that there were so many other mutations. I went through some of their names, and these are quite important recognized mutations. So coming to my work as the clinical director at Roche, I'm responsible for, as the physician of the study, responsible for BFAST study. It's a blood-based, so the way we recruit our patients into our study is by blood-based next generation sequencing. So patients don't need to have biopsies. Lung cancer patients, when they are diagnosed with cancer, advanced malignancy or non-resectable malignancy, are offered a blood-based test. So like kidney function test or checking their hemoglobin. We perform a F1 liquid assay, which then goes off to our Boston office in the USA, where they perform the exome sequencing of a huge panel of genetic markers, and based on the mutation that's picked up, we then allow patients in to participate in one of these cohorts. So we have ALK positive patients who can go into the ALK positive cohort, RET positive patients into RET cohort, blood tumor mutational burden positive patients can go into this cohort, ROS1 positive patients can go into this cohort, BRAF patients can go into this cohort, EGFR exon 20 positive patients can go into a very recently approved cohort. So at the moment, we have about 6 arms, which are, some of them have completed recruitment, some of them are open. For instance, BRAF and exon 20 arm are open. And if patients, if they do not have a mutation that we can drug currently, they go on to a natural history cohort where rest of the patients are picked up and their natural history is followed up. Here is the sites. Our BFAST study is running in 165 sites in over 27 countries. Here's the footprint of the study. And I shared this to the session that, the pie chart is just not to say, oh, we understand so much about lung cancer now. Look, we are doing genomic subdivision. It doesn't stop there, but we are taking it to the next level. So what if they are positive with these cancers? Can we drug these mutations? Can we positively benefit these patients by really going after the trigger, the driver mutation, and help these patients? And I think the EGFR example, I think you can clearly appreciate that median overall survival for around 7 to 8 months to have increased to 3 years is a success story worth replicating with other mutations. Right. So this is not the only progress in the current landscape of lung cancer treatment. In 2013, when I was NIHR academic clinical fellow starting in Leeds, Science reported that checkpoint inhibitors, immunotherapy of cancer, as the breakthrough of the year. My PhD was in immunology, and when I joined as a academic clinical fellow, my mentors and senior clinicians were really advising me to move away from immunology because it was said that, well, immunology has had 60, 70, 80 years to make a difference for cancer. People have been talking about silver bullet and all that. No progress has been made. But look at the genomic field and the developments there. So this is the better path, career path to take. So I mean, I'm not saying they were wrong. They were very correct in their assessment of saying that, look, the genomic pathway is a potential field that is going to have an immense impact on patient survival and treatment. But to discount immunology was probably a little bit of an early judgment call. So 2013, checkpoint inhibitors become the breakthrough, designated to be breakthrough of the year by Science, and not for wrong reasons. You can see the Keynote 189 study updated result. Let me introduce you to pembrolizumab. This is a PD-1 antibody. It binds to the PD-1 receptor on T cells, and it pretty much takes the brakes off the immune system. So there are various ways of explaining it, but the quick way of understanding it is that you have a car and the brakes have been applied, simply meaning that the immune system is not able to attack the cancer. because of PD-1 expression, PD-L1 expression from the tumor side. It's expressing PD-L1, PD-L1 meaning ligand 1, and this PD-L1 binds to T cells, pretty much telling, leave me alone, I'm your self cell, and this is a tumor microenvironment dynamic. So you have a anti-PD-1 antibody which blocks the binding of PD-L1 onto the T cell, pretty much giving a free hand for T cells to go and attack the tumor. So the overall survival here was in the updated result was shown to be 22 months. So maybe not as wonderfully dramatic as EGFR, but to increase from 8 months median overall survival to 22 months overall survival is a significant progress. And we in drug development, in the pharma, and in the academia are really working hard to work towards cancer-free status for these patients and prolong these numbers to as close to normal as possible. So, so I think I'll stop about the landscape of lung cancer. I'll quickly address how things changed since my recent talk with NODFA on the landscape of cancer, sorry, no, apologize, not cancer, COVID vaccine development to now, where we have some vaccines that have gained approval, maybe not full approval, but accelerated or limited approval in many countries. So I think the number 180 is a bit of an understatement. It's a little old, but nonetheless, be it 220 doesn't make much difference. Many of them are in very early development and may never see the daylight. As many approved vaccines which are already in clinical studies may make the development of earlier vaccines not feasible. But nonetheless, we have multiple vaccines now available, and when you're running a clinical study, you're already in an experimental situation where you don't know what your drug is going to do, because it's still working towards approval so many of the times. And add to that a unknown entity of a new a vaccine, which people don't know either what the adverse events and how cross reactions are going to be. So you got to treat both. You cannot not say, look, no, it's okay, we'll continue with COVID as it is. Neither can you say, okay, you know what, this is more important, let's not treat the cancer, because it's both need to be treated. So we do have to find a way forward. So basically, it's a company-wide discussion, company-wide directive to see, especially for studies that have immune modulators as the study treatment, what's the impact? So, we engage with sites, we speak to them, and there are questions. We have a patient who's on your study now. They are about to receive a COVID vaccine. What do you think we should do? It's typically a question that pretty much lands on my side, and I have to guide them through, in a way that both of us are comfortable in the steps that we are taking. So what is the guidance what are the steps that we think through is what I'd like to go over. So first, I think we have to acknowledge that there are multiple COVID vaccines in development, and there are platforms such as mRNA vaccines, which we have very limited experience prior to this. To be honest, when I was previously talking about the landscape of COVID vaccines, for me, mRNA was a very experimental a vaccine methodology. And somebody asked me, okay, will you give mRNA vaccine? I was like, I'll have to simply look at the data. I'm not seeing it positively, neither negatively. It's a new platform. I simply have to see the data to say whether this is a vaccine that I would opt for. And the data is absolutely fantastic. And if I had the opportunity, I'd definitely have the mRNA vaccine, no problems at all. So um, it's all about data. So with the SARS-CoV vaccines, there's very limited experience with these vaccines. And any data that exists in the context of the study which got the approval. And data is as limited as what the study data is available at the moment. And the data for the vaccine in the context of a concurrent anti-cancer therapy, you can imagine, is even more limited. So how do we chart this territory where already the data is limited, and then with concurrent cancer treatment the data is even more limited, and you have the immune system being modulated by the vaccine on one side, and on the other side you've taken the brakes off the immune system by giving checkpoint inhibitors, for example. So how do we make decisions? And frankly, we go back to, in our ALS training, advanced life support training, we go A, B, C, D, so likewise, we step back and we say, look, we are here deciding whether we need to give the vaccine or not. It's all about risk and benefit. It's all about risk and benefit. It's, if you reduce things down to chunks that you can intellectually interrogate, consider, and take the next step. So what we simply say is decisions to administer vaccine should be individualized by the patients, by the physicians in consultation with the patients, based on the risk of SARS-CoV infection and the potential benefit from the vaccine they are likely to derive, and how the patient is doing, their general condition, their underlying disease, the severity of COVID outbreak in their region, and the cancer's treatment status that they are at. And so it then becomes, rather than a broad brushed guidance, you now individualizing to the patient. You're taking all of their clinical scenario into equation, and then you're able to proceed further and focus in on the patient. And SARS-CoV vaccines must be given in accordance with the approval label. So whatever the label says, follow the advice. And there is the only restriction in our protocol that exists for checkpoint inhibitors, for example, is a live attenuated vaccine. And most of the vaccines available, no, all the vaccines available. So there are few and far between live attenuated vaccines in development. So frankly, all the approved vaccines and those that are coming into their phase 3, already in phase 3, none of them are live attenuated vaccines. I'm pretty sure that other vaccine methodologies such as subunit vaccine, viral vector vaccine, the mRNA vaccine can substitute. So, if and when live attenuated vaccine becomes available, our guidance will be, well, can we choose another vaccine instead of a live attenuated vaccine? So at the moment, we are not there. Let's individualize the decision for each patient. That's pretty much the end of my talk. Thank you.
Thank you very much, Vijay. Yeah, I'll let you know if you can just stop sharing your screen. So, yeah. Vijay, can you hear me?
Yes, very well. Oh, yeah. Shall I stop sharing my screen?
Exactly. Yeah, if you can stop sharing the screen.
Right. I have to figure out how to do that.
If you can go on the top of the page,
Oh, yes.
it says stop sharing.
Yes. More. Oh, no. Oh, stop sharing. Okay.
Exactly.
Done.
Now we are back over there.
Perfect.
Okay. So Vijay, first of all, excellent talk as before, because I have listened to your previous talk also, and this one is as good as before. And that's what I was expecting from you. And I think so that's what the audience were expecting from you. When I was talking to one of your other colleagues in the hospital and other, one or two on the telephonic conversation, I told them that Vijay is coming to talk about it. And they said, oh, is it the same Vijay who did the previously? So thank you very much for that.
Thank you. That's very kind.
Yeah. Okay. So just to reinforce you, you might have noticed that when Vijay was talking, there was another invasion in which somebody, starts speaking. And but due to the reason that we have already have all the things in place to catch those, inappropriate people to come in. So I think so that we did get rid of them because I recognize them. Who are they? So I just removed them from our sessions. And there are about 12 or 13 people who like to join this session. And in which out of 12 or 13 people, I do not know that how many of them are, the genuine people who like to join, and how many of them are the people who just want to come and play in the session. So I apologize personally on all those people who likes to join. That unfortunately we won't be allowing them for any new people to join because of a recent event which just happened about 20 minutes ago, and we do not want to destroy their teaching session. Also, they are more than welcome to watch it live on the Facebook, which is going live on National Overseas Doctors Family UK, Facebook page. And if any questions, they can either text me or write it down on the Facebook, and we will take it from there. So now, can I request Dr. Asif Shah, who is a consultant cardiothoracic heart and lung transplant surgeon in UK, to please give his talk.
Thank you very much, Kashif, and thanks for the invitation and having me here. And a very interesting talk by the VJ. I mean, especially from the surgeon's point of view, to hear and know about the genome and the gene level, because our work is disease the same, but work is very different. So my talk will be mainly focused on kind of practical impacts on the treatment, mainly from the surgical point of view. And can I share my screen here? Is that getting shared yet?
It is, yeah. If you can make it big, then it will be fine. Yeah, that's
perfect. So I'm a cardiothoracic transplant surgeon. So mainly my talk will focus on the kind of surgical management of the lung disease, and as much as we know so far, the impact of the COVID. So I just kept the talk very, very simple and easy for everyone in the audience, depending on which background or specialty or knowledge they are, just to some understanding of the basic treatment of the lung cancer. So as Vijay quite explained in detail, there's a lot of work being done in the research with the immunotherapy and with the chemotherapy, but which certainly has increased the survival to some extent. But so far, I mean, surgery is the only treatment in the lung cancer which is complete curative. But that's again a very limited to which type of the tumor and which stage, which is crucial. So from the treatment point of view of the lung cancer, it's very three basic factors which depends upon. Number one, it has to be which type of the lung cancer. certain more aggressive, some slow, some intermediate. And the second most important component is the stage of, let me see if I open the laser. Yes. So the second most important is the stage of the lung cancer. So which exactly stage the patient has presented, that will determine the long-term outcome and its prognosis. And the third, from surgical point of view, what is the general condition of the patient to offer any curative surgery, whether he will be able to tolerate or not. So far, surgery is the most commonly used in the basic treatment, primarily treatment for the lung cancer, mainly if it's confined to the chest without any metastasis. But if the patient already presented with the metastasis, there's a very, very limited role of the surgery in that condition. So as Vijay already shared the slide, so generally primarily two types of lung cancer which we come across. Majority, 85% of the non-small cell lung cancer, which are adenocarcinoma, squamous, and large cell. And this is the group of the lung cancer which are offered to the treatment. While 15% of the patient, they present with a small cell lung cancer. Now, this is a very, very aggressive disease, small cell lung cancer. Even before the patient presents with the 2-centimeter nodule incidental finding, he already would have tumor metastasized to his brain or adrenals or other organs. So only some very, very few lucky patients with incidental pickup of small lung cancer at a very early stage could have a benefit, but otherwise it's extremely aggressive disease and very limited you can offer from treatment point of view here. So all the work is being done, and where you can make a difference is all in the non-small cell lung cancer, yeah. So the options, it's one thing is very important to remember, that any cancer, it's a systemic disease. Either it's lung cancer or cancer of any other organ, it's very have to make understand it's a systemic disease. Yeah. So no single therapy is enough to treat that disease completely. So that's why all the cancer, like all other the organs cancer, the adequate and optimal therapy is discussed more in the multidisciplinary approach, which involves obviously surgeon, then our oncologist, radiologist, because every stage has a different treatment options, and all the plans are discussed in a multidisciplinary meeting involving all these specialties experts available. Yeah. And the most important factor is that it's the stage of the lung which determines what would be the best for the patient here. So how we stage the lung cancer? So it's three, primarily TNM, like any other tumor. It's tumor, node, and the metastasis. So the tumor, it's different divided from T1 to T4 depending on the size and location of the tumor. And the second component of the staging is the lymph node involvement, whether there are any local or regional or contralateral lymph nodes involved. So the best outcome of lung cancer surgery with the curative intent is the earliest the patient presents. So if it's a stage 1 and stage 2, they have the best outcome. Stage 3, there is some role of surgery still, but goes beyond more to treat the systemic disease with the chemotherapy, immunotherapy. And as the stage progresses, survival goes way, way down. To keep it very simple, how we stage the tumor, like any other tumor, basic TNM staging system. T for the tumor, which we divide from T1 to T4, depending on the size and location of the tumor. Is it 3 centimeter, less than 3 centimeter, bigger than 5 centimeter, invading the chest wall? And the second component is the crucial, is the lymph nodes involvement. Yeah, is it N1 disease, which is a very localized to that particular segment of the lobe, or N2 disease, which is a more mediastinal disease, and N3 is a contralateral or the advanced disease. And obviously metastasis, whether it's M0 or it's not there. So it's The whole T&M staging of the lung cancer is quite complicated because there's a lot of arithmetic table, but just to keep things very simple, in a very simple way for every person to understand. So stage 1, small spot on the X-ray CT, no lymph nodes involved. And that stage presents the best outcome if the surgery is offered at primary stage. The 5-year survival is 80% and beyond. Yeah. Stage 2, when the tumor primarily is larger than 3 centimeter and the lymph nodes involved, but only in the draining area called the N1 station. And that's when surgery is offered, again, with the adjuvant chemotherapy, they have a better outcome, but not as stage 1, which I would say 50 to 60%. Now, stage 3 is a bit more advanced, where the lymph nodes involved in the center of the chest. And it's a multi-modality treatment, surgery, chemotherapy, radiotherapy, either to give the neoadjuvant chemotherapy that is before the surgery to bring down the systemic disease. But all these plans are discussed in a multidisciplinary settings. Yeah. Stage 4, very limited role of surgery, but apart from the palliation. Yeah. So basic for a thoracic surgeon, very, very important to understand the full detailed anatomy of the lungs, of the lymphatic segments, lymphatic drainage. So because that are the basic principles of any oncological surgery. So the way we stage the lung cancer, apart from the tumor, which is size-wise, the second important factor is the lymph nodes, which is the draining lymph nodes. And in the oncological cardiothoracic term, we term them station from station 14 to station 1. So starting with the 12, 13, 14 are the very segmental, subsegmental level within a lobe, and up to station 10, that's all contained within a one lobe. Either it's the upper lobe or the middle lobe, lower lobe, same on the left side, upper lobe or the lower lobe. So this is the first area of the draining of any lung cancer, which is again, we call it N1. If a disease limited within the lobe, that disease is called the N1 node. And when it further progresses to the mediastinal nodes, if they come to the tumor cells are positive in station 2 or station 4, which are the mediastinal lymph nodes, you can see in the pretracheal and paratracheal area. Or if it's a station 7 is a very important, which is called subcarinal. That's again a mediastinal disease, which differentiates from N1 to N2 disease. Yeah. Same station 8, periesophageal, station 9, and coming up to station 5, station 6. So it's to determine any optimal treatment, it's very, very important to exactly classify and to correctly stage the patient to get the optimal treatment offered to him. Yeah. How we evaluate the lymph nodes when the patient presents, obviously after the radiologically, the CT scan, PET scan, which show whether the lymph nodes are enlarged or not, which depends on the size of the lymph nodes. So the next thing is to confirmation of the diagnosis, whether those lymph nodes contain the cancer cells or not. And to get the biopsy of those lymph nodes, so that's the two main procedures. We use bronchoscopy or the EPUS, which is mainly performed by our respiratory physicians, or the surgical mediastinopy, which is performed by the surgeon. So that's how the EPUS is performed. So basically it's endobronchial ultrasound and needle biopsy. So typical bronchoscope, which is that ultrasound probe, and the needle comes out there, and that takes specimen of the lymph node to confirm the cells. So all the mediastinal lymph nodes, they can be accessed station 2, station 4, station 7, and some of the station 10, they can be accessed through the EPUS. That's the way diagrammatic explanation of how the EPUS is performed. So a bronchoscope is entered through your tracheobronchial tree, and the ultrasound, it confirms, you can see it here, that's the ultrasonic image of the lymph node. And a needle is pierced through the lymph node and take the sample of the cells to confirm whether the lymph node's disease is positive or not. Alternative is the surgical medistinoscopy, which is a surgical procedure. It's again the confirmation of whether the disease has progressed to the N2 stage or not. A medistinoscope is passed just in front of the trachea with a small incision in the neck. Station 2, station 4, and station 7, they are sampled with the medistinoscope. That's a view of the medistinoscope. You can see that once you mobilize the tissue, that's the lymph node, which is a black looking. So these are the directly biopsied and sent to the histology to outrule or confirm the involvement of those lymph nodes. So once we have a disease, we have accurate staging if it's stage 1 and stage 2 predominantly. So the next stage is who can be offered for the surgery. So treatment, the role of a surgery in particular lung cancer, so these are the group of the patient who get the best outcome for the long-term survival and prognosis, where they don't have any lymph node disease. The tumor is only limited to within the lung parenchyma and within a lobe. Then the second group, which called the N1 disease. Primary tumor is there, but there is a disease in their adjacent draining area, which is the kind of Hilar disease, still called N1, still not better result outcome as N0, but still much better, 50 to 60% 5-year survival. Now the N2 disease, when the lymph nodes get involved in the mediastinum, so that's a bit of gray area. There's not long-term survival as good as N1 disease, but certainly two strategies, either to offer the neoadjuvant chemotherapy first to those patients given the systemic chemotherapy to bring down the systematic metastasis and bring down the size of the tumor, or if a surgery is being done followed by the chemotherapy. So that's the N2 disease here. While N3, if it's N3 lymph nodes on the contralateral side, that's beyond the surgery. There's no benefit of patient offering the surgery. Exactly as I said, it's primary tumor on the left upper lobe, and the lymph nodes after the hilar lymph node and mediastinal, when the lymph node become involved with the contralateral side, which is N3 disease. And in that case, surgery has a no role. So mainly it's the palliation chemo or radiotherapy, depending on symptomatic wise. So when a patient is fit for the surgery in stage 1 or stage 2, or some patients in stage 3, so the important thing when they refer for the surgery is the 3 very important questions. Can the operation be tolerated to the patient? So how's his general fitness level regarding his comorbidities? Because removal of any part of the lung, it's a major surgery, and what's the fitness level of that patient? And after removing that particular part of the lung, whether it's a small segment or one lobe, or is it a whole lung, whether he will be able to live his normal life after a section. That's the second important question. And the third important is, can the tumor be removed completely? That means the whole primary tumors and the lymph nodes. If any of the doubt, that tumor involving any adjacent structure, and you think it cannot be removed completely, there's absolutely no point. It's a waste of time. You can't offer any prognostic benefit to that patient. So the very important, the whole tumor and the adjacent lymph node should be excised completely, leaving nothing behind. So 3 very crucial considerations which should be put into when offering someone a curative surgery. So what are the goals of the surgery, and what are the types of the surgery? So very simple. Number 1 principle, remove the tumor completely. Absolutely no lymph node, nothing should be left behind. Remove all the draining lymph nodes on the side of the cancer. And the other thing to keep in mind as well, so preserve the lung function as much so the patient can have a good quality of life afterwards. I mean, if you remove the 2 lobes on the one side with the intention of complete excision of the tumor, but somebody with the poor pulmonary reserves, if he afterwards on oxygen dependent, so we are not giving him any benefit of it here. So very crucial, tumor has to come out completely along with its lymph node drainage. And after removing that part of the lung, whether that patient will be able to maintain a normal quality of life or not. Yeah. So the type of the surgery which are offered in the lung cancer, if it is simplest small tiny lesion, it's called the wedge resection. So just a small piece of a lobe, like a V section, it can be taken out. Or if it can be done as a segment resection, like every lobe, upper lobe has four segments, 2 segments in the lingula, 5 segments in the lower lobe. So again, that's anatomical resection to take out that complete segment in that particular lobe. Or the most commonest approach is the lobectomy. That means taking out the whole lobe of that lung which is involved, along with its lymphatic drainage, pulmonary vein, pulmonary arteries. So this is the more anatomical resection and the best outcome with the recurrence point of view. Or if a tumor is involving the 2 lobes, so you have to consideration given to the pneumonectomy, which means removal of the complete lung on the one side, depending on the tumor, right or the left. So how much lung can be removed? As I said before, must have enough of the tissue left behind so the patient can have a normal quality of life. So these are the different pulmonary function tests, the assessment, different tools which can be carried out pre-operatively, that if 30% of the lung is removed, or the 40% of lung is removed, or the 50% lung is removed, what will be the residual vital capacity and what's the function of the remaining lung. Some people, the tumor are resectable, but the function of the lungs are quite poor, so very limited you can offer. And as I said, they all can be assessed with the pulmonary function test and the diffusion test, which is pretty routine for the preoperative surgery. So we'll touch on how the surgery is performed for lung cancer. So standard orthodox conventional treatment was open thoracotomy, which opening the chest in the 4th or the 5th intercostal space, open up the chest completely, take out the lung. But with the recent decade or so, there's a very increased to perform the lobectomy with the video assisted, which is called the VATS. So no big incision, 3 small ports incision, put a camera in and take it out. And in the UK at the minute, more than 80% of the lung cancer surgeries are being performed by the VATS. Yeah. That's the standard position of a patient lying on the side with the angle table. And that you can see where the position going to be monitored, video monitor, where you can see where the camera in the chest and your port for the instruments. So that's the inside view of the right side of the VATS, video assisted. So you can see that the lung is collapsed. So that's the right side of the chest. So the right upper lobe, right middle lobe, and the right lower lobe. And that's the picture taken the way you perform a wedge resection. So if it's a small nodule here, that can be identified and held it there. And the lung resection can be performed with the staples, yeah, which cut it and divide it by themselves. That's a wedge resection again. You can see that's the margins where the stapler was applied. This is the remaining lung. And that further can be applied with a stapler, and that wedge can be removed. And after removing that particular segment of the lung, that's the retrieval basket, so that lung can put it in, it can be taken out of the chest here. So basic principles, VATS lobectomy. So three important segments: bronchus, artery, and the 3 veins. So basically 3-eyed structure has to be identified and divided. So that's the way, that's your camera port, that's the staple port, and that's the clamp. And that's what the anatomical looks like. So the bronchus divided, as well as the relevant draining artery of that segment of the lung, and the relevant vein if it's upper vein. So that's to be excised here. That's the view of the VATS. So this is the dissection and mobilization of the pulmonary vein. You can see that pulmonary vein is completely mobilized, put a tie around it, and then move the staple around and which divides and cuts. Similarly, that's the view of the pulmonary artery, same way mobilized, and then it can be divided with the staple to free up that anatomical area of the lung. So sometimes the tumor, they're still resectable, but involving the chest wall. So you can see that CT, a very peripherally located tumor, but invading the chest wall. So if the lymph nodes are negative in the N2 disease, so that group of the patient, they offer very good long-term outcome as well. So the chest wall can be resected along with the adjacent tumor and with the ribs, and they can be reconstructed here. Same patient, you can see the primary tumor only localized peripherally, but adjacent to the chest wall. And that's the whole tumor has been removed with the three to four ribs. And if it's more than 5 centimeter of 4 ribs, certainly chest wall can be reconstructed with the mesh or Gore-Tex or different stuff are available here. So after a typical lung resection surgery, what to expect? Patient will come out of the theater with the chest tube, which generally stays 2 to 3. The chest tube helps to inflate the remaining lungs, or if there's any collection, any blood, so that should be drained out as well. Breathing exercises from the day 1 to prevent pneumonia, out of the bed chair day 1, ambulate. That's a very crucial step. If it's open thoracotomy is very painful in C, and so usually we offer patient epidural, so they should be pain-free. That helps with their breathing exercises and their mobility. And that's where the main difference comes from a thoracotomy. Conventional open surgery, very painful, long stay, 5 to 6 days, while the VATS, there's no incision, small stab wound, and in 2 to 3 days, patient is ready to go home. So Vijay spoke a lot about COVID. So being a surgeon, to be honest with you, there's a lot unknown. We don't know about that. But it certainly have putting a very bad impact on patients waiting for the lung surgery, because surgery is the only curative treatment for the lung cancer. And generally where our catalyst was, the patient from diagnosis to definitive surgery was a cutoff of 4 weeks. Due to COVID, delayed of the beds, currently patients are waiting 8 to 12 weeks. Yeah. So that certainly is affecting very, very badly current COVID situation. And again, if a patient with the lung cancer, if he became the COVID positive, he has to wait at least 4 weeks or until the CT of the chest is completely clear of any COVID changes before you can offer him any surgery. So to summarize, very simple, the use of surgery lung cancer depends exactly on the type of the lung cancer and more importantly on the stage of the lung cancer and the patient general condition. Surgery is most commonly used cancer if it's confined to the chest and only the regional lymph nodes. Lobectomy is the gold standard to take out of the whole lobe and removal of all associated lymph nodes, remaining the adequate lung functions behind. Recent decade, increasing more and more training and more people doing with the VATS, it had made the procedure much easier and very limited 2 to 3 days stay in the hospital, very low pain as well, and quick recovery. If the tumor involves the other lobes, chest wall reconstruction can be performed or the pneumonectomy. And certainly, as I said, I put mainly focus on the surgical aspects of the lung cancer disease, but certainly it's a combination of, if anything beyond stage 1, if any of the lymph nodes is positive, either stage 1, adjuvant chemotherapy is very, very helpful. Thank you.
Thank you very much, Asif. That is, I must say, really interesting, very interesting. And I myself have learned a lot with your presentation, because you can well imagine, as a pediatric surgeon in children's, we do come across doing the VATS procedure,
Correct.
doing any kind of, lymph node biopsies, or do kind of a minimum resection of the lungs also. But few things which you have shown me, I must say you're a very brave surgeon dealing with the pulmonary vein and pulmonary artery. And the way you have put your clips around the pulmonary artery, if somebody brave enough can do it?
I mean, the 80% of work of a thoracic surgery is a lung cancer surgery, So lobectomy, that's kind of every day on your list, there are 1 or 2 patients for the lobectomy. So you get so much of volume to perform, So certainly that increases the number of the cases, your reflexes, and obviously you learn from your mistake. Things do sometimes get wrong, but generally it's the volume of the cases, So like in any procedure, the more you've done, the more you come in a comfort zone.
That's very good. I'll start with the questions with Asif, with you first. I've got quite a few questions,
Sure, yeah.
So let me start with a question with your technique, EBUS technique, that is endotracheal, lymph node biopsy, which is a very interesting, technique. And this questions comes from Pakistan. They were just wondering whether you've shown that, pictures and the way you've shown the techniques and everything. They were just asking, first question, is this technique is available in Pakistan?
To be completely honest with you, I'm not sure. I don't think so. Maybe 1 or 2 individual people who would have returned from North America or the European train, they might be able to do it, but I haven't heard, to be honest. Not sure yet. Because the best here, this EBUS is all performed by the respiratory physicians. So which is a help great to us, to surgeon, EBUS patient is awake, just under sedation, they can be performed rather than putting under GA mediastinoscopy. So it's a great help, and with the speeds up, with the time, which is not to be wasted in the diagnosis, before offering a definitive treatment. Pakistan, I'm not sure.
Now, which leads to another question which just popped up, and I will ask this question in relation to the same thing. This says that there's an interesting question, I think. So this says, can you help in educating and training of EBUS, procedures in, I must say, in Pakistan?
Certainly, we'll have to, as I said, they're mainly performed by the respiratory physicians. So we surgeons, we don't perform EBUS here, because bronchoscopy, that's like any GI surgeon, his everyday work is with the scope. Same with the respiratory surgeon, their everyday work is with the bronchoscope, not for the cancer, for any other reasons as well. Yeah, there would be certainly workshops available on the College of Physicians website as well, and the Society of Respiratory Physicians. Yeah, but yeah, certainly, I mean, you can take a note and we can look for it. If anyone interested or willing, especially if we find somebody from Pakistan or India, so they would be very happy to offer. Why not?
That's good. Now, which leads to another question regarding your total lung resection. You have shown a picture doing the, lung lobectomy, taking care of the veins and the arteries. The question is that, how do you, or what do you do with the bronchus?
So bronchus, there are, I mean, with this all VATS and the recent surgery, so there are different sizes of the staples. So staples for the vascular margins are different, staples for the artery is different. At the same time, the staples are available for the bronchus as well. So they are stapled as like the way the pulmonary artery or the pulmonary vein. Yeah.
So it means that you use staples to just staple them like the way you do
yes, because with the VATS, the drawback with the VATS is you lose your tactile feeling. Obviously, you cannot put your hand in, you cannot feel it. So all you go with your radiological findings, and basically it's possible because of only all the surgical clips, which can be ported through small 2 to 3 centimeter port. Yeah.
Yeah, which take me to, there are a few questions which I will email you and you can answer them, which takes me to last question for you, that another relevant one. How COVID affect the lung cancer treatment? I think so that's a very important, relevant question, especially with the COVID-19 going on, affecting the lungs. So how can it affect the lung cancer patients?
So biggest problem, which is the unfortunate thing, the patient suffering at the minute, is the kind of delay in offering them treatment. So generally in the UK, in the NHS, within the 4 to 5 weeks from the time of the diagnosis, the patient should be offered definitive surgery. Now, due to COVID thing, all the beds and the theaters, they are packed with the COVID patients. So certainly the waiting list of the lung cancer surgery has gone doubled, So instead of offering in the four weeks, at the minute, those lung cancer patients, they are waiting for 8 to 12 weeks, which certainly not good with the bit of tumor progression. And if unfortunately somebody who becomes a COVID positive with the known lung cancer, so again, until you have to get interval CT scans, at least 4 weeks. So you cannot offer a surgery until completely the radiologically COVID changes are cleared. Now, because the mortality of a lobectomy is 1 to 2%, but if you performed a lobectomy or any lung surgery on a COVID patient, with all the recent trial, what they showed, the mortality has increased up to 40%. So you can imagine it's tenfold increase, even more than that in the mortality if you operate on a COVID positive patient with the lung changes. Yeah. So a lot unknown, but certainly they are suffering badly with the increased waiting times.
That's good. I need to ask you another one question because that again, pops up. Again, due to the COVID-19 era, which is all going on, what do you think that how much chemotherapy and radiotherapy is effective if you see as a journal or if you see in relation to the COVID-19, which is happening now?
So Vijay's talk was very interesting, the papers he presented. So basically, as I said, any cancer disease is a systemic disease. So the only best outcome with the surgery is if it's a very early lung cancer, small 3 centimeter lymph nodes with, primary tumor with the negative lymph nodes. Surgery might be alone enough. If any involvement of the lymph nodes, you have to add the adjuvant chemotherapy. Now, chemotherapy or the radiotherapy alone at itself, they increase the survival 15 to 20%. That's the maximum, but none of the treatment is a curative.
Thank you very much, Asif. That's a very nice, session of questions with you. Now, can I request Dr. Vijay? Because Vijay's, talk about vaccines and everything, and people have huge interest in asking the questions and everything. The question which I've got with you is, first of all, there are new strains of COVID-19, coming up, and quite a lot of people are quite worried about whether the present vaccine, which is either Pfizer, Moderna, AstraZeneca, or whatever is the vaccine is this, how effective is those vaccines are on the new strains, or are we still doing some kind of research to see whether they are effective or not? So what are your thoughts about it?
I mean, a quick disqualifier is, although when I came back from the US back to the UK, there were a couple of opportunities that came my way in COVID vaccine development, but my interest lied in doing something about this cancer problem that the world is facing currently. So I chose cancer drug development. But my PhD was in vaccines, so I've been following the field with great interest. And with years of exposure in the vaccine field, I think I can say that I have some experience to comment on these issues. So this is a process of natural selection that's going on with the COVID-19 SARS-CoV-2 virus currently in pandemic. And it is only to be expected that there will be different strains of mutant viruses that are going to emerge in different parts of the world. But that should not hinder or change the ground level work of global vaccination. That should continue. And there is already a lot of surveillance work which is going on in picking up these strains, genomically sequencing them, and identifying the differences, and booster doses being made ready for future deployment. So yes, to answer your question directly, Kasif, the resistant, I wouldn't call it resistant, but they may well be. These mutant strains may be resistant to the current vaccine, but that does not mean that we slow down our current vaccination strategy. As you know, the predominant pandemic is with the wild type, as it were, the one that we have vaccines for. The strain is, it's bubbling up in a small population, in a small area, and if unchecked, it is likely to, spread because the process of natural selection is against, against the common strain, and you create the space within which it can develop. So, and vaccine is not the only strategy that we are deploying against these viruses. Washing hands, the mask as the key one, and social distancing. So these are all other factors which will slow down. Yes, booster vaccines need to be made, responding to these strains emerging, but it is very much a single booster that might be, that we needed. And there are many other vaccine strategies. For instance, at the minute, most of the vaccines are targeting the S protein of the virus, which is what binds to the ACE2 side of the human cells. There are other vaccines which are targeting more, rather than the branch mutations, more truncal type of mutations where these tiny variations in the S protein doesn't matter. There are other targets that the immune system can develop immune response against with the help of vaccine, which is not so mutable, which is common to all of these. So there are multiple vaccines. We watch the space. I wouldn't be, I'd be cautious, but would recommend that the vaccination program be rolled out in full swing. That's the way to go.
Vijay, that's an excellent answer, I must say. And it has answered quite a lot of questions which my patient asked me, or my colleagues asked me, or my family members asked me regarding the new strains and everything, and whether to get the vaccine by themselves or not, or whether they go ahead for the vaccine, whether they don't go for the vaccine. There are so many questions, but thank you very much. You have enlightened me also so that I can satisfy them. That's excellent. Now, which took me to I'll say that because we are running short of time. So this will be my last question. I think so. One of the research fellow who was listening to your talk very carefully, and I think so you're the best person to answer this question. They says that, can you perform next generation sequencing on conventional biopsy?
Yes, is the short answer. So the next generation sequencing, I think, I think it was year 2004 when, not so far away from where I live in Cambridge, you have the Sanger Institute, which helped in sequencing the whole genome, the Human Genome Project. The costs were very, very prohibitive. Now with NGS, the next gen sequencing, the speed with which we can do whole exome sequencing, for example, and the cost has come down very significantly. As you know, the studies, the BFAST study that I'm currently involved with, gives a little bit of respite to Asif and his colleagues that they won't be asked to go do repeat biopsies in identifying which way the mutation. So, there's a driver mutation, you throw in the drug, which targets that mutation, the cancer then finds a way to, as a resistance mechanism to escape. as it were, and for the cancer to progress. So instead of repeated biopsies being required, you can have repeat blood tests which pick up the cell-free DNA circulating in the blood from the tumor cells and say, well, this is the resistance mechanism. So next-gen sequencing can also be performed on conventional biopsies. For instance, when Kasif sends the biopsy from his lymph node, and we want to know, for instance, Asif talked quite a bit about adjuvant and neoadjuvant therapies. We are working on building another platform for adjuvant treatment specifically, not so much with the neoadjuvant at the moment, but we are thinking about neoadjuvant as well with targeted therapies. So the conventional biopsy also can be subjected to next-gen sequencing with identification of a particular mutation. And when Asif completes the surgery, we know what a mutation the patient's positive for, and we can determine what is the best adjuvant treatment that the patient can be offered. So do watch the space. Roche is working on a adjuvant study which may potentially come out if it goes through all the approval processes. So we are talking. We want to set up another. So yeah, that would be my slightly elaborate answer. Thank you.
Thank you very much, Vijay. That's again a very nicely answered and everything, which took me to the end of our session. So I really like to thank our audience. We have got a very minimum audience, and I again apologize that due to a small ditch or another, an invasion attack on our teaching sessions, but we have controlled it really well. And that's the reason we didn't allow the other participants to join. So apologies for that, but they can watch each and everything on the Facebook. It is still there, so they can watch it at later. My special thanks to Vijay, who is always there, whatever he do, whatever kind of research he's doing, by one message to him, and he'll say, Kashi, what do you want from me? So thank you very much, Vijay, for all doing this. And Asif, I don't have to say anything to Asif, because what you call it in our own language, that Asif is my yar. He's my
player.
So thank you very much, Asif, for that. So
very welcome.
So at the moment, I think so. I'm just gonna close that session now, and I'm gonna stop the recording also. And let me just stop the recording first.